Welcome to the digestive system and introduction on chapter 37. I like this system a lot. This is one of my favorites. So I hope that I'll impart some knowledge to you so you'll understand and appreciate this GI system that we have. So let's start with the mouth. That's where food is ingested, and the teeth and the tongue and the salivary glands help grind up that food, and we have some secretions of digestive enzymes like amylase, and that initiates the breakdown of carbohydrates. And then the tongue helps mixing with saliva and presses it back into the back of the throat, which is actually the pharynx. The pharynx is a muscular structure that's shared by the digestive and the respiratory tract. So there is a part where not only do we swallow there, but we breathe there. So you can imagine that might be where we might aspirate. Now there is a trap door to prevent food from entering the respiratory tract, but you know when you cough, that trap door opens. And then if you cough and then breathe, have you ever done that, like with water, and then you start choking because you may have aspirated some water? That's how you feel. Well, the elderly can do that too, because they can cough and their cough is a little weak and their trap doors are a little weak also. So you can imagine that they can aspirate pretty easily. So we've got that pharynx that has just a small amount, and let me just show you that picture here. So let's look here at this picture. So you can see that one area there, that in the pharynx, that is not only for the respiratory tract but the GI tract as well. And then we move into the esophagus. And the esophagus is a long muscular tube that has gravity as well as some peristalsis or muscular movement to move the food down. Because you know, if you were laying flat and you only required gravity to move your food down into your stomach, it wouldn't do it, would it? So you need a little muscular action in the esophagus to get the food down into the stomach. Peristalsis, great word to know. So the stomach has three parts to it. The fundus of the stomach, the body of the stomach, and the pylorus at the very end of the stomach. Interesting, it also has muscular layers to help kind of grind up the food and mix it up. But I remember when I first started studying the GI tract, and I went and I bought like a stomach, right? You know, model of a stomach. And I thought, this is great. And I opened it up and it was totally empty. It was an empty, hollow organ, because it is. It has room for food to come in. But it does have vasculature, which is how we can get ulcers and bleed. But it's pretty interesting that it just also has these little rivets in there called rugae, which allows the stomach to expand and contract. That's how we can eat large meals or small meals. So moving along with the muscle layers that mix the food together, and it all gets into a semi-liquid mass called chyme. And the gastric secretions have renin that starts the breakdown of milk products, lipase that breaks down fats, and pepsid and hydrochloric acid that begins to digest proteins. And then you've got the pyloric sphincter right at the end of the stomach. Now that's another door that we have. And it too can get a little floppy, loose. We can have reflux from the duodenum up into the stomach. And we can have food go right out of the stomach into the duodenum. So a lot of ulcers are in the duodenum, and that's the small part of the intestine. Now remember, the small intestine has three parts, right? So it has the duodenum, which is the first part coming right out of the stomach. A lot of ulcers are there. In the book it says 20 feet of small intestine. You'll see 20, 21 feet. 6 of one, half a dozen of the other. It's pretty long, right? Long. And if you look at the picture here at the small intestine, it's just like a roller coaster. It goes up and down and in and out and twists around. And it is hard to see things that are happening in the small intestine. We know digestion takes place there, but sometimes there's problems in the small intestine. Now, there's a few ways physicians can see what's happening in the small intestine. They can't scope it, but they could do a barium swallow and follow the barium and look at it with barium. Also, now we have the capsule endoscopy, which is a little pill. It's not a little pill, it's about the size of your little fingernail. And you swallow that and it has camera in it that can last about 8 hours, and it takes pictures. I'm going to explain that a little bit more when we get to tests and procedures, but it's just fits right in here to the small intestine of how we can look at the small intestine and see what's happening. So again, 3 parts of the small intestine: the duodenum, the jejunum, and the ileum. So in the duodenum, that's where we get digestive enzymes from the gallbladder and from the pancreas. So that's 3 layers of muscular tissue. We've got membranes that secrete digestive enzymes, and we've got the pancreas. And what moves all this food along in that small intestine? Well, we've got little villi, which are little finger-like tips that not only do they absorb nutrition, but they also help move food along. And we also have the muscle layers that contract to continue mixing the chyme, moving it towards the large intestine. Now, those muscles, sometimes they can cramp, and that can cause a lot of discomfort. So sometimes you'll feel that cramping feeling after eating. That could be a muscle cramp in your intestines. So let's move to the large intestine. So if you look at the picture here at the appendix, so that's right where the small intestine meets the large intestine. That's the ileocecal valve. So the ileum part of the small intestine, and then the cecum part of the large intestine. Now, there's some diseases that happen right here, so we will be talking about that a little later, but I want you to get the visual of the ileum and the cecum, or the ileocecal valve. And when doctors do colonoscopies, they can usually only get as far as the ileocecal valve. That scope won't go much farther than that, maybe just a little bit past it into just a little bit of the small intestine, but again, they can't see a whole lot. So we've got the large intestine that goes up the right side of the abdomen, the ascending colon, the transverse colon that goes across, and if you just look at the picture, you can see there transverses right across the abdomen, and then the descending colon. We also have the rectum is called the sigmoid colon, and the last 6 to 8 inches of the large intestine is the rectum, which ends with the anus, and that's where the waste leaves the body. Unlike the small intestine, the large intestine has no villi and secretes no digestive enzymes. So basically, what does it do? It absorbs water from the chyme and eliminates the remaining solid waste in the form of feces. And usually feces is formed hard. That's why we need to keep hydrated, so it's not so hard that it's difficult to pass. And again, remember, in the elderly, if they don't drink enough fluids, what can happen? They can get constipated. Their stools can be really, really hard. So now let's look at the accessory organs. I guess I want you to just take a peek here with this anatomy and physiology picture. I'm going to be talking about the gallbladder, the liver, the pancreas. These are accessory organs. It's not part of the main digestive system, as you can see here on this picture. So here's a great picture of the accessory organs. And you do have this picture It's on page 696, if you want to see a little bit better. I'll get to that in a minute. So, anatomy and physiology of the liver. Oh my gosh, the liver is amazing. It does like 500 things. In fact, if you've ever seen a book, a liver book, it is bigger than the whole GI system book. It does so much. And the pretty cool thing about the liver too is that, it can be transplanted. You can even transplant a lobe of the liver. So you can have a live donor that gives part of their liver to someone who needs a liver, and that means they can get help sooner than waiting for the liver to totally fail. Once it starts failing, you're in pretty bad shape because it just does so much. So anyway, the liver, the largest internal organ in the body. The term hepatic. So from now on, when I talk about hepatic, that means liver. So that's an important word to know. So the book says that there are 4 lobes in the liver. Now, if you look at the picture, it looks like there's only 2 lobes, doesn't it? Well, they actually call them sections of the liver. So the sections of the liver can be divided up into functions, but you can donate a section of the liver. I know that's a little bit confusing, but you can see on page 695, there's something called the caudate lobe, and that is counted as a lobe. So when they talk about 4 lobes of the liver, they might be including that lobe as well. That's where just a lot of the, you can see the picture of the liver lobule. That's where a lot of the connections and the blood vessels are. And when you do a liver transplant, it is really intense. It takes a long time because of this intense system of blood vessels and function of the liver. All right, so blood from the aorta is delivered to the liver via the hepatic artery. The portal vein delivers blood from the intestines to the liver. The portal blood circulates through the liver and is transported to the inferior vena cava by the hepatic vein. So the aorta and the veins are a little bit switched in the liver. Specialized hepatic cells allow the liver to carry out many critical functions. So you have the Kupffer cells. Those ingest old red blood cells. And by ingesting old red blood cells, can be what makes a person look jaundiced, because the breakdown of red blood cells is bile. So that jaundice look can be the breakdown of the red blood cells. There's parenchymal cells that carry out various metabolic functions, including metabolism, carbohydrates, fats, and proteins, and steroids and detoxification of potentially harmful substances. Because remember, we talk about how the liver is a filter. And I used to think that was like the main function of the liver. It filters out the bad stuff, our waste products. It filters out drugs, but it does so many more things than that. And that detoxification with age decreases. So because of that, drug dosages may not be as high as maybe when the person was taking medication at 50, 60 years old. As they age, because of the detoxification not being quite up to par, and it decreases, drug dosages might be decreased also. Otherwise, the patient may get too much drug in their system. Albumin ties into that also, as far as drug binding to albumin. I guess that's another conversation, isn't it? All right, so metabolism of glucose, protein, and lipids. That's important. I kind of skipped through the bile production, and excretion. So if you'll take a peek at that, it's quite an intense system. Again, a really good picture on page 696, if you want to look at that, figure 37.6, because there you can see how the liver can transfer the bile that it makes and put it into the storage tank of the gallbladder, and then with the hepatic duct, and then the gallbladder holds the bile until it's needed for digestion, and that's the cystic duct, and then the common bile duct is kind of where they both go into the digestive system. All right. So the common bile duct goes into the small intestine, and the bile emulsifies fat, which if you've got gallbladder issues and you've eaten a fatty meal, that's when you're going to get problems. That's when you get uncomfortable. That's when you might get a gallbladder attacked. Now, another thing that might happen in the gallbladder is the gallbladder doesn't excrete all the bile. So the ejection part of the gallbladder isn't working great. That can also lead to gall problems. So you know you can get gallbladder stones and you can get gallbladder dysfunction. So there's a couple things that can cause you to have gallbladder problems. Now, do you need the gallbladder? No. It's just a storage tank. The liver is totally capable of just dumping it right into the small intestine. So you can live without a gallbladder without a problem. But sometimes it might lead to some diarrhea, especially at first after your gallbladder surgery. Here I go, getting off track again, sorry. But you know, it's good to talk about things when they first pop up, and then if I repeat them again, well, then you got a double dose and you'll remember it. So let's just talk. So when fat passes in the duodenum, so I'm still under bile production and excretion on page 694. So when fats pass into the duodenum, the gallbladder and the liver respond by delivering the bile through the common bile duct into the small intestine. There it gets emulsified, and it neutralizes the acidic chyme as it leaves the stomach, and it plays a role in absorption of fat-soluble vitamins. Also, metabolism. So metabolism of glucose, protein, and lipids is another function of the liver. The process is called glycogenesis. When the glucose level in the blood falls, the process is reversed to glycogenolysis, and the glucose molecules are returned to the blood. Gluconeogenesis is the third process by which the liver maintains blood glucose. So I know you probably learned those probably in fundamentals or even your class before that. So we're just going to kind of just refresh your memory about that. Also, the protein and lipid metabolism that occur, ammonia in the protein metabolism I want to talk about for a second, because some non-essential amino acids, protein, albumin, and globulin, and clotting factors are synthesized in the liver. So if you've got liver problems, you've got clotting problems, you've got albumin problems, and also the protein metabolism is the conversion of ammonia to urea. Now, ammonia is a problem when you have liver disease. That's a lab test that might be monitored. And it can also make your brain a little confused. So if your ammonia level is high, you might be in a confused state. So they might give K-oxalate to help get rid of that ammonia and make you go to the bathroom so you can get rid of that. So as you can see, it says if ammonia accumulates in the blood, it has toxic effects on brain tissue. Then the lipid metabolism, it breaks down the fats, blood coagulation, prothrombin, fibrin are synthesized by the liver. And then the detoxification I talked about. With the age, it decreases, so some dosages may be inadequate. You might have to change those. Immunity, so antibodies and other substances help to resist infection are produced in the liver. Hormone metabolism, estrogen, adrenocorticoids, testosterone, and aldosterone. If these hormones are not metabolized, they accumulate, causing exaggerated effects on their target organs. Now, if you're still with me on page 696, it's that great picture that's up there on this page. It can help you see things a little bit clearer. So let's look at it for a second, because I really want you to understand. See the pancreas? It's kind of that white or beige maybe color. Now that it's got something going down the middle of it. That's the pancreatic duct. You've got the tail of the pancreas. Now these are accessory organs. So we've got the pancreas, the gallbladder, and the liver. And then you can see the spleen is up there as well. So let's just continue to talk about the biliary tract. The bile is produced by the liver and channeled into the common duct. Anatomy and physiology of the pancreas. So the head of the pancreas lies against the duodenum. So I want you to take a peek at that. And the tail lies next to the spleen. So you can see why it's called the tail. It's smaller. And there are pancreatic cancers, and one can affect the tail and one can affect the head. And the ability to bounce back from those cancers, it varies. One is a better diagnosis than the other. All right, so what are the functions of the pancreas? Well, they have two functions, exocrine and endocrine. The exocrine functions is the digestive function. So the pancreatic enzymes trypsin, amylase, and lipase act on partially digested foods in the small intestine. So trypsin plays a role in digestion of protein. It's not activated until it enters the duodenum. Amylase acts with intestinal enzymes to reduce starch, sucrose, and fructose to glucose. And lipase acts on emulsifying fats. And then the endocrine function. That's probably the function that you know the best because it's related to our diabetics. So these islets have alpha cells, beta cells, delta cells, and pp cells. So the beta cells produce and secrete insulin. The delta cells produce somatostatin, which inhibits the release of glucagon and insulin. The pp cells secrete pancreatic polypeptides, and then glucagon is secreted when the blood glucose level falls. It stimulates the liver to convert glycogen into glucose. And insulin is secreted into the blood when the blood glucose rises and after a meal. So there we've got our anatomy and physiology of the liver. Look at all those things it does. Anatomy and physiology of the biliary tract, the common duct, the bile duct, the cystic duct. Anatomy and physiology of the pancreas, how it's an endocrine and an exocrine gland. Pretty cool. So now let's talk about the biliary tract. I guess I really did that already, didn't I? Got carried away, but let's go here. So bile's yellow-green liquid that has several important functions. It contains bile salts, which are essential for emulsification and digestion of fats. It also provides a medium for excretion of bilirubin. Now, bilirubin, yellow, right? Jaundice from the liver. The function of the biliary tract is to deliver bile from the liver to the duodenum. Bile flows from the liver to the gallbladder where it's stored and concentrated. Then we talked about the pancreas. I'll go to the next page here. I really like this picture though. I just wanted to call your attention because it's pretty clear. So the anatomy and physiology of the pancreas. The pancreas is a fish-shaped organ and it's got the exocrine and endocrine glands. Exocrine of the pancreas carried out via cinar tissues. These enzymes are needed for the digestion of proteins, fats, and carbohydrates. And then the endocrine function of the pancreas is carried out by the clusters of cells. The glucagon is secreted and it stimulates the liver to convert glycogen to glucose. Insulin is secreted when the blood glucose rises after a meal, and it stimulates the use of glucose by the cells so that a normal blood glucose level is maintained. Now, we said that a couple different ways, so hopefully that is a little clearer now. So what are some age-related changes that occur in the GI system? Well, the teeth. Now, teeth haven't always been something that everybody paid a lot of attention to. Now we know a lot more. Now we have fluoride. We didn't always have fluoride. And that helps keep our teeth in good condition. We know we have to brush our teeth at least twice a day. We should use our, floss, right? Get 6-month checkups. But they didn't do that in these elderly people. They just had their teeth mechanically get worn down with age. And when there was a problem, then they got it taken care of. But they didn't just prophylactically go to the doctor and have their teeth cleaned. Just wasn't done. So the jaw can be affected by osteoarthritis. Loss of taste buds with age. So that's why they don't like to eat. Food doesn't taste good to them. It's not because you could take them to a gourmet restaurant and the food still wouldn't taste that great because they get a loss of taste buds. Erexostomia, which is dry mouth, is very common. So we're going to give our patients great mouth care because a dry mouth can grow bacteria. So we don't want that. And they say inflammation can be a leading cause of disease as well as cholesterol. So inflammation we want to cut down, and that's what we want to do when we're young, so that when we have age-related changes we don't have a lot of problems. So walls of the esophagus and stomach thin with aging and secretions lessen. Production of hydrochloric acid and digestive enzymes decrease, so they can't digest their food, they can't get all the vitamins from their food. Motor activity slows, so they don't empty their stomach as quickly. And also we've got that pyloric sphincter that's not functioning that well. Also, the food could just fall right into the small intestine, and hopefully it can get absorbed there, some of the vitamins. But the gastric muscle slows. Not much significant changes in the small intestine that we know of, right? Some vitamin mineral absorption changes. In the large intestine, the muscle layer and mucosa atrophy. So what's a big problem for the elderly? Constipation, because the movements of the colon, so we got 2 reasons on this page. The movement of the colon slows. They're not active, right? They're not physically walking around as much, moving around. And when they do it slow, and also they have they don't drink a lot, so they're dehydrated. So constipation, big problem. And then the anal sphincter tone, the strength decreases. So they might have a little leakage from time to time. And also, you know, they say when you gotta go, right? If you don't go when you have the urge goes away. And then you have to wait for the next time. So that's why there's a lot of problems there. Let's go to assessment. So our assessment of our patients. So why are they here? What's the reason for seeking care? They're having any weight changes, problems with digestion or indigestion, digestive disturbance, vomiting, heartburn, pain, changes in bowel elimination. Also, what are they, not just what is wrong, but what are they doing for it? So you want to know, are they taking anything? So that leads you to meds, right? So what meds are they on to help them? Then you want to know their past history also. So do they have a history of diabetes, hepatitis, anemia? And now that you've learned about the GI tract a little bit, you may see how all of these problems fit into the history. Because we talked about ulcers, gallbladder disease, hepatitis, the liver, diabetes, the pancreas, right? Liver dysfunction, cancers. Document any food allergies or intolerances. List their medications. Are they on any estrogens or contraception? Diuretics, corticosteroids, sulfonamides, nonsteroidals for their pain, maybe arthritis at that point. Those are all might be really important. So what about a functional assessment? Remember what a functional assessment is. It's what they do. So how about their dietary habits? What do they do when they eat? So what's their pattern of eating? Do they eat 3 large meals, 1 large meal, multiple small meals? Now, when I talk about the GI system throughout this whole next few chapters, I'm always going to be saying a few small meals because it's going to be really important in the elderly and in the GI system. Frequent small meals. Who invented this eating 3 large meals? I don't know. It's not a good idea. So we also want to know the foods that they like and don't like. Are they taking any food supplements? We want to know about liver disease or any exposure to liver causing problems. Toxins. What did they do? Maybe they were a janitor and worked with some toxins. And how about Tylenol? Do they take a lot of Tylenol? Maybe they do because they hurt. So they take Tylenol. And how much Tylenol can we have in a day? 3 grams, 3,000 milligrams. So you got to add that up. And as a nurse giving meds, you want to be sure that you're adding any meds that have Tylenol in it. Be sure you add all that Tylenol up that they're getting in a day. Because even cough medicine can have Tylenol in it. And also alcohol use. And we always associate alcohol with liver disease, but there's so many other things that can go along with that. All right, so let's look at their physical self. So we want to look, what color is their skin? Is it pink? Is it jaundiced? Jaundice is a great word. It's a golden yellow skin color associated with liver dysfunction. And let's look at their head and neck. You want to look in their mouth and check out their teeth, their tongue, their mucous membranes. Are they dry? Are they moist? Pink, what color? Is there anything growing on their tongue? You want to notice all these things. And let's look at their eyes also. So inspect the sclera of the eyes. And they can turn yellow with liver disease, and that can be called scleral icterus. Also, that is also seen in dark-skinned people. And then let's look at their chest. So we want to check for, in men, gynecomastia, and look for spider angiomas. So if you come across a patient and he has a big belly, right? It could be ascites, swelling, fluids in the abdomen from probably liver disease. Could be cancer also. There's different types of cancers that make fluid accumulate in the abdomen. But right now we'll stick to this, okay? All right, so spider angiomas, they really look like a little spider. It's blood vessels that sprout out like a spider. These are small visible vessels that are shaped like spiders, and they will be on the abdomen. Be sure you take their bowel sounds, right? And you want to divide that abdomen into 4 quadrants, belly button being the middle of the imaginary lines. So inspect that abdomen. Let's look at it first. Before we touch it, let's look at it. So you're going to look for something called striae. Now this is on page 698 in your book, and there's a great picture of striae. Very important to know. They look like stretch marks, but it could be related to liver disease. But they look like stretch marks. That's important to remember. So again, inspect the skin of the abdomen for color, texture, scars, striae, stretch marks. Do you notice any aortic pulsations around the belly button? Do you notice that there's ascites or fluid accumulation in the peritoneal cavity? Measure the abdomen. So again, I'll refer you to that picture, figure 37.8. See how the belly is distended or large? Measure that right at the umbilicus. It's important that you measure at the same place every time, so documentation helps the next nurse know where you measured it. Also, I used to take like a marker, and I would mark where I had placed the tape. Now, that tape measure, leave it in the room, because that's going to be the patient's tape measure from now on. And you can document how many centimeters, inches, however you want to say it, is on that mark, on the tape measure. All right, then we want to auscultate. Auscultate before palpating, because palpation can alter normal bowel sounds. Normal bowel sounds include clicks and gurgles that occur 5 to 30 times per minute. So you should listen to each quadrant for at least 2 minutes. Now, do we know? Because once you hear a noise, you'll move on. It's when you don't hear a noise, you need to stick it out and wait and see how long it takes until you do hear something. Because you might have to listen up to 5 minutes before recording bowel sounds, because they might be slow. So you can describe bowel sounds as absent, present, increased, high-pitched, decreased, tinkling, gushing, gurgling. Now, loud gurgling sounds are called borborygmia. What another great word, right? Borborygmia. And then also, you want to notice the facial expressions of the patient, especially when you start touching their abdomen. Do they wince? You know, they might not say anything, so that's why you got to look at their face. Are they reacting to your touch? They might tell you, oh, your hands are cold, but are they in pain when you touch anywhere on the abdomen? Percussion. Now,
We don't really percuss too well. That was an old way. Doctors still do it, but it was before stethoscopes where we couldn't listen, so they would tap out sounds to see whether they had some hollow sounds or not. There's something called Tympanic Sounds, and that is high-pitched hollow sound, similar to a kettle drum. Tympany is heard more often than dullness. And then palpation. So that's you're pressing down on the patient. Another thing, when you press down, right, and you're checking for any discomfort, you're looking at their face, you're checking for any fullnesses or any bumps or anything. But another thing you're going to check, then when you let go, your hands come off the abdomen, that's called rebound. So if they wince when you rebound, that is a sign. That's called rebound tenderness. And that can occur when there's something going on inside of the abdomen. Now, an enlarged, increased liver may be felt below the right rib margin, and that's called hepatomegaly, enlarged liver. You might feel that. It takes a little bit of experience to feel the edge of the liver. Then we come to the rectum and anus. Gloves should be worn during that time when you look at their private area. And if you insert a glove lubricated finger into the rectum, you can ask them to bear down. You can feel their anal sphincter if you want to get into that type of exam. Right. So now let's talk about, before I move on, still on page 699, box 37.1, there's an assessment of the patient with a disorder of the digestive tract or accessory organs. So you might look through that. That's all the things we just talked about, kind of rolled into a little box. So that's kind of cool. So let's go to endoscopic exams. So an endoscope permits direct inspection of hollow organs. It's a long scope that the physician, a gastroenterologist, will, sometimes surgeons do it, but it's really the job of a gastroenterologist. And they look into the hollow organs with a scope. You do need a permission. You do need a consent. So endoscopes can be rigid or flexible, fiber optic, and that means they can also see at the end. So at the very end is a light, and the doctor can look through with an eye scope into the bowel, the stomach, the esophagus, the mouth, with an endoscope. So if you're going to go into the GI, upper GI system, that's a gastroendoscopy. You need to sign consent, as I said before. Now, before they do an endoscope, they are going to give the patient a sedative, because you have that gag reflex when they put something down your throat. So they want to prevent that gag reflex. So a patient will be given a sedative. The most serious complication of endoscopy is perforation of the digestive tract. So physicians really try to avoid that. But sometimes they run into big tumors or blood vessels that are very, very sensitive to touch, and they start bleeding. But then the doctor at that point can take care of that. He can burn it. He can anticoagulate it by burning it, or by sometimes tying it with a rubber band. So that they do have some tricks that they can stop bleeding, but rupturing something is a problem. And let me just tell you now, it's going to be true in the whole GI system. If they perforate any part of the GI tract, the contents are going to pour into the abdomen. and then you've got a problem. Because if it's stool, it's dirty. If it's food, well, it's going to cause problems and inflammation in the abdomen, and it could require surgery, right? Because that abdomen's got to be washed out with saline and maybe antibiotics. So perforation is not a good thing. All right. So here's where I get to talk about the capsule endoscopy. Here they call it the camera capsule. It's about the size of a large vitamin tablet. The patient swallows the capsule. Now leads are applied to the abdomen, which is attached to a recording device. So the patient wears a little recorder on their belt. And so as they swallow this capsule and it's tumbling in the GI system, it's taking pictures. Both ends have a camera. So as it tumbles, it's taking all these pictures, and those go to the recorder, and then the next day, 24 hours later, they bring it into the doctor, and the doctor can look at the recording and see if there's a problem in the GI system. So it's really, really cool that they can do that. And this is that good way of seeing the small intestine as well. Then under radiologic studies, there's that barium swallow. It's a small bowel series. There's also a barium enema. So barium is radiopaque. It's like white. Patient will drink that, and x-rays can be taken and follow that radiopaque barium. The problem with that is you've got to get it out of the system right away because it can get hard. So they're usually given something to help them get rid of that barium. And if they're going to have a colonoscopy, they might have to have a cleaning out of the colon so the doctor can see anything going on along the tissues, polyps, cancers. And you know polyps are precancerous. So if they get a polyp out, that's a good thing. They always send that to examination to be looked at to see if it is a precancerous lesion. And then if it is, then they're going to have a colonoscopy probably every year or so. All right. CT scans, MRIs, all of those, remember, if they get dye, we have to check to see if they're allergic. A HIDA scan is another thing that goes along with the gallbladder. You can do an ultrasound of the gallbladder and see stones. But if you want to see the function of the gallbladder, you're going to do a HIDA scan. Now I'm still on page 700. So HIDA is a nuclear imaging scan that uses a radioactive substance that's given in the vein. All right. Ultrasound uses sound waves. It's kind of like a submarine, how they use the sound waves to go down to the bottom of the floor and bounce back and give an image to a submarine. Well, that's what an ultrasound does. It goes down into the body and sees a vision and then bounces that up, back up to a picture. The retrograde cholangiopancreatography, or ERCP, that's endoscopic retrograde cholangiopancreatography. That's where the physician will look an endoscope. So he puts a scope down into the stomach, out the stomach, into the small intestine, and then where that ampule, or there's a little sphincter there where the gallbladder empties into the small intestine, he can look into that. And if there's a stone stuck in the duct there, he can pull it out maybe with a basket. Maybe. He can't go into the gallbladder though, but he can go into the duct. That's the ERCP. That's pretty cool too. All right, liver biopsy. That's pretty important. So you want to get some baseline vital signs and also blood coagulation tests. You need a consent for sure, right? because anything invasive always needs a consent. Now you're going to tell the patient what to expect. A needle biopsy, position the patient supine with the right arm behind the head, if you just kind of want to do that position so you can see what that's like. And then feel your ribs there, because they're going to go in between the ribs into the liver. So that's why they put their arm up, so they can kind of spread out the rib area to go into the liver. For a needle biopsy, position the patient with the right arm above the head. Place a pad under the right arm, the right chest. Physician instructs the patient to take a deep breath that moves the lungs out of the way, and inserts the needle and removes a piece of tissue, a puncture kind of thing. Aspirates for the study. Afterwards, it's really important, you guys as nurses, if you have to follow a patient after a liver biopsy, remember the liver has coagulation, so you're going to have to watch for bleeding. So there's going to be a pressure dressing placed over the puncture site, and it should be checked for bleeding every 15 minutes for the first hour, and then every 30 minutes for the next hour. Monitor the vital signs at the same time. Now remember that tachycardia, restlessness, hypotension can all be signs of what? Blood loss or hypovolemia. And then pneumothorax, they might present like if the doctor accidentally punctured the lung, the patient wasn't able to take a deep breath, or sometimes the physician aims wrong. They usually do this under x-ray, but it can happen. In that case, the pneumothorax would be produced by the physician nicking a lung, and the patient would present with restlessness and tachypnea, or rapid. Tachy always means fast, right? So fast breathing, where they're trying to get enough air. That's why they're breathing fast. The physician usually orders the patient to be kept on the right side for at least 2 hours. And the reason that is because the pressure of the body puts weight on that potentially bleeding area. So the weight of the body can stop the bleeding. But you do have to periodically check for bleeding. If you notice a little bit of bleeding, sometimes I'll circle that bleeding site, and then the next time you check, you'll see if it's more or the same. And that's something you would document. The primary complication of liver biopsy is hemorrhage or pneumothorax. So bleeding is a possibility because of the liver's blood supply and impaired coagulation with liver disease. Okay, let's go to lab tests. And there is a map of these I'm going to pull you to, but I just want to talk about these for a minute. So the most common lab tests related to the digestive tract are blood and urine. So Helicobacter pylori. So when they do an endoscope into the stomach, if the patient's been having stomach problems or reflux problems or heartburn type problems, maybe they have an infection, Helicobacter pylori. They found that a lot of ulcers are caused by that. So the doctor would do a biopsy during the endoscope just to be sure, do they have that infection? Because that would be treated with antibiotics and proton pump inhibitors. They'll do analysis of breath, urine, serum, stool, and gastric biopsy tissues. Now you can do an H. pylori breath test. It's not as accurate as an endoscopy because you get a lot of negatives when they really might have it. So it's really better just to have an endoscopy. Studies that can be done to assess nutritional status would be albumin. That's a protein, right? So if they've got low albumin, they could be suffering from protein malnutrition. Cultures Transferrin is another liver test. Other liver functions, bilirubin, urine and fecal urinoglobulin, serum protein, ammonia level, vitamin K, that's a clotting factor. INR, especially if they're on Coumadin or something, they might want to check that. Plus, it's a bleeding time, international ratio. The prothrombin time, liver function test, ALT, AST, alk phosphatase, aminotransferase, and a CBC, good old CBC. Some calcium, triglycerides. Stool specimens can be analyzed for fat content related to gallbladder disease. If cancer is suspected, now there's some blood level cancer antigens that can be tested for. A CA19-9 would be pancreatic, and a CEA is colon cancer. I'm going to talk about that again in just a minute. These are markers. So they can, if they're elevated, it might mean you better look at this to see if there's a problem. So now let's turn to table 37.1. We're going to talk a little bit more about some of these tests. So we're going to refer back to these also as we talk about upper and lower GI tests. So just remember in the general test and purpose that we're always going to assess our patient for allergies to see if they're allergic to dye, iodine, or shellfish. And we're going to get a consent if we need it. So the upper GI or GI series, that is where they would swallow the barium. The bowel, small bowel series detects abnormalities of the small intestine. The barium enema, CT scan. And as I go through these, you can look and read through them. You can read through their action, the preparation, and the nursing care. One thing I want to throw in here, they do something called gastric analysis. They used to put down an NG tube and test the pH of the stomach. Now they have a new test, and it's called a gastric analysis test, and this is pretty important for you to remember. And they take a dye orally, and it checks for the hydrochloric acid in the stomach. And then it's excreted in the urine 2 hours later. So that's a newer type of test. So there's the cholangiography or T-tube IV percutaneous transhepatic surgical test where they check on the gallbladder. Portal venogram where they check into the liver system. Remember, portal and hepatic. Liver scan. That's going to collect in the liver. It's an IV contrast. Gallbladder scan, hepatobiliary scintigraphy. Okay, ultrasound of the gallbladder. MRI, MRCP. Now, the MRCP, I'll just call your attention to that for a second. It's on page 703 under MRI. And that is where they look at the pancreas as well. So, cholangio, gallbladder, pancreatography, pancreas. So this is an X-ray that looks at the liver and the pancreas. Now, the ERCP looked at the gallbladder. It's an EGD with an extension to the gallbladder. But it's different. It's a scope. This is dye. Important to remember the difference there. And then the MRI of the liver. Then there's endoscopic test, the EGD, that looks into the stomach and the esophagus. The endoscopic retrograde cholangiography, which utilizes the bile ducts and gallbladder, ERCP. I'm on upper digestive and accessory organs now on the bottom of 703. So if you'll turn the page to 704, colonoscopy visualizes the anus, rectum, and entire colon. Now, what's the difference between a colonoscopy and sigmoidoscopy? A lot of times, most colon cancers are on the left side of the colon. So a sigmoidoscopy a lot of times is good enough. But for people who have problems, maybe Crohn's disease or ulcerative colitis, they're going to want to visualize the whole colon. Also, people who have colon cancer suspected, maybe blood in the stool, they want to look at the whole colon. So they would do a whole colonoscopy. But a sigmoidoscopy is they're only going to look at the sigmoid part. And they're not as sedated either. Because and if you notice how the colon goes, it makes several twists and turns. The doctor has to take a scope and turn those curves, and it can be discomforting to the patient. So that's why they're sedated. But in the sigmoidoscopy, they just go straight up into the left side of the colon. It's not as uncomfortable. The capsule endoscopy, I was talking about the video images of the entire digestive system. And by the way, when they excrete that out, it just drops in. It is biodegradable. It just flushes away, and it's no harm to our water system at all. All right, some blood tests. So serum electrolytes, of course, is important, or potassium if we're vomiting or have nausea. That's important. Protein, electrophoresis. The CEA, which is our colon GI malignancy test. It's not 100%, but if it's high, it needs to be looked at. Bilirubin, elevated in cirrhosis and gallstones. Alk phosphatase, elevated with liver or bone disease, the ALP. Serum enzymes, elevated by tissue damage, and that's ALT. Serum triglycerides, that can also be elevated in pancreatic disorders. ProTime, INR, those can be prolonged due to liver disease or vitamin K deficiencies. Serum protein, we want to look at the albumin level of our patients. Can result from renal disease or inflammation. Amylase is another pancreatic enzyme. Urine studies, might want to look at some urine amylase. The tumor markers, as I was mentioning before, and again, I'm on 705 if you're following with me. Tumor markers. So that CEA is colon. The pancreatic POA, it's also CA19-9, is a pancreatic cancer. Just for a little extra knowledge, I'll throw in that the CA125 is ovarian. Breast cancer is the CA15.3, or the BRCA also is another tumor marker. AFP is a liver marker for liver tumor. Then there's some esophageal function tests. Monitors pH monitoring to detect reflux. And I think I mentioned that a little bit earlier too. It doesn't really say it in the book exactly the way I told you, but trust me when I tell you that that checking for the gastric analysis, they take the dye orally to check the hydrochloric acid, and it gets excreted in the urine. But they can also do a pH monitoring, and they put a tube down. Manometry measures the lower esophageal sphincter to see if they're having any problems there. Maybe that's why they have nausea and vomiting. And then the Bernstein test, hydrochloric acid, saline instilled into the esophagus. It's another test they do. Turn the page and go to table 37.1 on 706, and it talks about stool analysis. So stool, ova, and parasite, if you'll see that, the first one is stool for occult blood. Well, that's, if you've ever done that, or if you've ever seen that done, it's a cardboard paper, and you put stool on 3 little tissue papers, and then you drop some blue dye on there, and then it can tell you if it has blood in it. Stool and ova and parasite. So if they suspect ova and parasites in the stool, do not put it in the refrigerator. So notice the patient preparation for that. Preparations are the same as for stool occult blood. It says no special care is required, but when I take you down to the stool exam in the text part, it says deliver stool specimens to the lab immediately. If temporary storage is necessary, specimens for ova and parasites must be kept warm. So do not put those in the fridge. Specimens for pathogens, however, are refrigerated, but ova and parasites, do not put them in the refrigerator. All right, then they might do fecal fat tests, test for pancreatic function, the secretin. So those are all in the table 37.1. But if you go down to the text part on page 706, and it talks about occult blood, and that's, you can't see the blood, but you can check for it. Occult means you really can't see it. And then I talked about the stool exam and to deliver stool specimens to the lab immediately. And here's some common therapeutic measures. So let's go to the next slide. Some common therapeutic measures. So when it says GI intubation, so that's going to be a tube like an NG tube, right? It does show different types of tubes on the next page, page 707. The Levin tube is probably the one we're most common with for NG tubes. There is a Salem sump that is a double lumen tube that they use. It has a vent. There's one with a balloon at the end. I'll talk about those in a second, but the regular intubation. So it's an NG tube. Now it can be for several reasons. It could be for feeding, right? And if it's going to be for feeding, you're going to always check patency of the tube before feeding. So remember how you did it in skills lab, where you might put some air in there into the stomach and listen with your stethoscope, and so you can hear the blub, and then you'll aspirate to see what you can get out of the stomach. And you may check for feeding, you might be checking pH, you might just be seeing what's in the stomach, coffee ground. All these things would be descripted and documented really well. So the variety of tubes, as it says, not only for feeding, but they're also for problems. So the Sangstick-Blakemore esophageal gastric balloon, it's like the second paragraph under GI intubation. Now, that's a special tube used to control bleeding in the esophagus. So what that is that it's an NG tube, but then they inflate the balloon at the end, and that pressure against the bleeding varices, or when I say esophageal varices, they're kind of like hemorrhoids in the stomach. So it pushes pressure against them to stop bleeding. But remember, if it's putting pressure against the esophagus, it may also affect the trachea as well. So you always have to check them for breathing problems. That's a big thing with that Sangstick-Blakemore. The PEG tubes used for feedings are placed in the stomach through an opening. So the way they do that is with an EGD. A doctor will do a regular EGD and he'll turn the lights down in the room. When he puts that scope into the stomach, he'll shine the light through from the stomach to the outside, and they'll see where to make an opening. And they cut that little opening and they put the PEG, it looks like kind of like a nipple in there, and it inflates with a balloon to hold it into place. And that's how they can get feedings into the stomach. It bypasses the whole alimentary, or from the mouth to the stomach. It bypasses that for feeding. And this is for people who can't swallow for one reason or another, whether they've had a stroke or maybe they have cancer, but they still need food. They still need nourishment. So they'll put in what they call a PEG tube, which is percutaneous, meaning going through the skin. So feedings may be delivered by gravity flow. So maybe it's just gonna drip by gravity. Sometimes it's put on an infusion pump, and there is one called a kangaroo pump that one side gives the feeding and the other side gives water. You'll see that when you get out into the field. But if you don't have a pump, you'll just use that the syringe barrel. And remember, you should change it every 24 hours, and it should just be for that one patient. So you'll keep that in the room and date that so that you know when that was first used. So many times I've walked in and there's no date or time on that tube, and you don't know when it was brought in. It could be 3 days old. So you want to use a fresh one every day, so document it. And also, you can put the date on it. All right, so I'm going to reiterate this again because it's so important. It's critical to confirm that the tube is in the stomach or the duodenum before administering feedings. So you're going to aspirate, check, and you're going to listen. So aspirate and listen. I'll be saying that a few times. Okay, let's turn the page. So page 708, and you can actually see the endoscope, which is kind of cool. And you can also see and put the PEG tube in, how it comes outside of the skin for feeding. All right, so we're going to always have the patient's head of bed elevated at least 30 degrees, because if you lay them down flat while they're getting a feeding, they can get that aspiration. So we always want to elevate their head of the bed, and we always want to check placement. And look at what are you aspirating anyway? Is it a lot? Maybe that means they're getting their feedings too fast. Or is it blood? Is it coffee ground? What is it? Document what you get and how much. If you put it back in, you won't have to count that as output. But if you take it out, or if it's just suction, that's counted as output. All right, so we're on page 708. Let's go down where it says dumping syndrome. You see that? That's the 1, 2, 3, 4, 5, 6, 7th dot on the second column. Dumping syndrome may occur with rapid feeding or concentrated formula. Signs and symptoms, now this is really important to know, which is why I'm calling your attention to it. Signs and symptoms are cold and sweat, abdominal distension, dizziness, weakness, rapid pulse rate, nausea, and diarrhea. If using a syringe to give the feeding, do the following. So remove the plunger from the barrel of the syringe, attach the barrel to the feeding tube, pinch or kink the tube while the syringe barrel is filled with formula to reduce the amount of air into the stomach. Hold the barrel no more than 18 inches above the insertion site. Now you'll be able to learn these things when you go to clinicals. but I do right this minute want you to remember about checking what's in the stomach, how much is there, can you hear the placement, and also I want you to know about the dumping syndrome. What does the patient exhibit? What are their signs and symptoms? We talked about abdominal distension. They break out into a cold sweat. They get dizzy, weak. Their pulse might be fast. Right? If you've got an infusion pump to deliver the feeding, that's good. You can kind of set it to how much the patient's supposed to get per hour. Continuous feedings are initially started at a rate of 10 to 20 mLs an hour, and that's to avoid that dumping syndrome that we need to know about. So we're going to start it out slow, make sure the patient can tolerate it. It might even be diluted so the patient can tolerate it more easily. And then it's usually every 12 to 8 hours. They usually take it off for a bit so the patient can get up or go for a shower. So there'll be a period of time where there is no feeding or that it has to be stopped. You can also give drugs through that feeding tube, which is good if the patient is having trouble swallowing. And to change the administration setting tube and bag every 24 hours. That goes for the big piston pump as well. Okay, GI decompression. So that's putting the NG tube down and putting the tube to suction to suck out what's in the stomach, to decompress the stomach. You can see those directions on page 709, and on figure 37.12 you can see the method of taping the NG tube, which you got to do in Skills Lab. All right, remember they've got to get water, so not only feeding, and yes, the feeding a lot of times is diluted, but that doesn't count as the water. So you need to give them water. In addition, there will be an order by the doctor to give so much water with your feeding. It's just like when you eat. You eat and drink. Well, so do they. They're just not getting to do it on their mouth. They have to do it right into their stomach. Be sure that you give good mouth care. They are NPO. Now, some stroke patients start out with a feeding tube, and then as they get better, they might soon be able to swallow. They might start with thickened liquids, but they still keep the feeding tube in, because what happens if then they resort and have another stroke or they get worse? So they keep the feeding tube in until definitely that person can get enough nutrition to keep them healthy. Okay, let's go to TPN. I'm going to drink a drink of water, sorry. So total parenteral nutrition, that's TPN. That's on page 709, the bottom of your book. So if the digestive tract has to be bypassed, and let's say, yeah, okay, you could put a feeding tube in like I just mentioned, but what if the rest of the gut's not working? But you still need to get nutrition, or you need gut rest. You need the whole GI system to be rested, but they still need nutrition. So you can give it IV, but it's really not in the vein of the arm. It's going to be in the superior vena cava, into a large blood vessel. You don't want to give it in the arm, because those are small blood vessels, and TPN has a high glucose level, and it can cause infection. It can irritate the blood vessel, so you give it into a big vein. Superior vena cava is pretty big. It's the biggest one. You've got an inferior and a superior vena cava. Superior is up by the chest, so that's why we're going to give it there. And then it dumps it right into the right atrium where there's a lot of blood flow. So it's diluted quickly, so that's really important. So if you're on page 709, so underneath the guy, you see the girl with the NG tube getting taped, and then the picture of the guy, and he's got the TPN going in to his subclavian vein. You can see it says entrance site up by his head there, by his hair. subclavian vein entrance site, the catheter that's tunneled up into the superior vena cava. So right under him, though, it says the feeding passes directly into the superior vena cava. Very important to remember. It's up there on the slides as well. Superior vena cava and the right atrium. This placement allows for rapid dilution. So if someone was to ask you, why are you putting it there? Well, you're going to tell them because it's so irritating to the veins and the arms that you want to put it in a big blood vessel, a large blood vessel, and that would be your vena cava. And it allows for rapid dilution because of all the blood volume there and concentrated feeding. You can also give regular IV feedings of water, glucose, electrolytes, minerals, and vitamins. Okay, let's turn the page. I want you to go to page 710 because we're still talking about the TPN. So you see the first dot where it says take great care to prevent infections, because remember that IV, that TPN, is going into the superior vena cava. If you got an infection there, it would be bad news. So you want to prevent infections at the insertion site. So always use sterile technique for site care. The exact procedure should be ordered or written in the agency's procedure manual. And you want to look for signs and symptoms of infection. So if you notice a redness or any pus or anything like that, you want to notify the doctor right away because that could send them into sepsis. Another thing in the second dot, go to the second dot because that's important also. It says monitor the flow rate. So normally the doctor will tell you how fast he wants that TPN to go in. Maybe 60 mLs an hour. So you would set that pump, it would be on a pump at 60 mLs an hour. But things happen. What if the CNA wants to turn the patient, or what if the flow gets blocked and it gets slowed down and it's not up to the way it should be? In other words, they're not getting as much as they should be per hour. So monitor the flow rate. Whatever you do, don't try to catch up. You know why? Because this has high glucose. Sometimes it's a D10, sometimes even D20. If you run that too fast, they're going to be almost like a diabetic, and they're going to get that symptoms of a diabetic where they get polyuria, polydipsia, polyphagia. So we're going to look for urine output here too, because that can be a sign that they're getting that TPN too fast. And that is under the third dot where it says monitor the patient for signs and symptoms of blood glucose change. The concentrated glucose solution can raise the blood glucose excessively, hyperglycemia. Elevated glucose stimulates the pancreas to produce more insulin, which may then cause a drop in blood glucose. So urine output, we know, is also a sign of hyperglycemia. Our PPP, polyuria, polyphagia, polydipsia, are signs of diabetes, right? So another thing right after that is to label the TPN lines and never use the TPN line catheter to administer drugs. Because not only is it maybe not mix well, but also you're introducing a needle into a sterile environment. That TPN, again, rich in glucose, infections can grow, so we don't want to inject anything in there. So label the TPN lines so that nobody accidentally administers drugs through there. All right, so I know this is pretty long, isn't it? So, but you can turn me off anytime, right? Turn it back on. Because I still want to talk about, oops, I pushed the button. Pre-op and post-op digestive surgery tract surgery. So I can just read that from the book. Basically, conditions of the digestive tract that might require surgery would be cancer, peptic ulcer disease, diverticulosis, appendicitis, polyps, obstruction, ulcerative colitis. So if you go under pre-op nursing care, there might be an oral preparation such as mag citrate or some cathartic to make them go to the bathroom to clear out the GI tract so they can have surgery. Because the doctor doesn't want to open them up and have some stool in their colon because that's infection. So you should always watch for a change in vital signs, heart rate, rhythm, hypotension, mental state change during that bowel cleansing process. And the reason that is because it makes you go to the bathroom. I mean, it turns it to diarrhea where you're almost like pooping out, clear. And you think you're clean, right? But that small intestine, that's 20 feet of bowel that you have to clean out. So you might not be totally clear. So they have to take the whole thing. And it tastes awful. What I've learned is that if you give it through a straw, it doesn't taste as bad because it can go straight to the back of their throat and bypass their taste buds. So I've also had people put like a candy drop, hard candy in their cheek so that the taste of the candy is there and they don't taste that awful taste of the cleaning. The diet is liquids for 24 hours before the surgery. Then if you go on down to post-op care, now they do use general anesthesia, and abdominal surgery causes a temporary loss of peristalsis. So you're always going to have to wait, after any surgery really, for the bowel sounds to return. Post-op care, you want to prevent gastric or abdominal distension, replace lost fluid, so they could be on an IV. They might have an nasogastric tube in place. So remember that is all I&O. Intake going in, output going out, no matter what tube or drainage it is. You want to count that as I&O. All right, so while we're in that area, let's talk about drug therapy here. Table 37.2, page 711. So these are GI drugs. So the first things you may have heard about was antacids, and those are merely to neutralize the acid in the stomach. Then the second would be H2 blockers, and those reduce the secretions of gastric acid, hydrogen blocking, histamine blocking, and that's Tagamet, Zantac, Pepsid, Axid. Those are all over the counter now. Proton pump inhibitors. Prilosec was the very first one that came out. I believe you can buy that over the counter now also. Nexium, Prevacid, Protonix, Acifex. Those also are proton pump inhibitors. The smartest one I love there is the Acifex. So ACI stands for acid, and the pH of the fex is pH. So it affects the acid pH. Don't you love it when the words tell you what they do? I love that. So that inhibits gastric acid secretion. Now the proton pump inhibitors, or PPIs, the way they work is at a cellular level. So they actually prevent the acid from being secreted into the stomach. So, and then there's mucosal barriers, which is, one is carafate, and it's a thick liquid that they swallow, and it's usually before meals and bedtime, AC and HS, and they swallow that and it coats the esophagus, the lining of the esophagus, stomach, and it prevents irritation. So that's a really good drug. It's a protective gel. The next one is the synthetic prostaglandin, Cytotec. It's often used to prevent gastric ulcers caused by NSAIDs. So those are all on page 711 in your table 37.2. I know you're going to get a lot in Pharm, but if you start learning here and then get it reinforced in Pharm, and we try to have those two work together. So when a patient has GERD, I want to talk about this now because they might be taking medicine for GERD, gastroesophageal reflux disease. But so if they're on medicine for GERD, they shouldn't have heartburn, right? But what if they do? Well, maybe the drug's not working then. The doctor needs to be notified. So if a patient is on a GERD medication and they develop heartburn, doctor needs to be notified. Okay. Anticholinergic drugs. I'm not going to go through all these. Anticholinergic are more drying type of drugs, atropine, scopolamine. Laxatives and stimulants, you know what those do. Bulk forming laxatives helps form bulk. And then the osmotic diuretics, osmotic laxatives, they pull more water into the stool so that they can go to the bathroom easier. And that's that magnesium citrate, that's that before a colonoscopy to help clear out the patient, clean them out. And then there's lubricants like mineral oil, fecal wetting agents, stool softeners, and then the lactulose, notice, that is more for liver patients. Does it say that anywhere here? Yeah, it says treats hepatic encephalopathy, lactulose. And then underneath the lactulose, there's one called Go Lightly. Yeah, that's a lie. It doesn't go lightly. You do not go lightly when you take that. All right, some anti-diarrheal agents, still on page 713. Opiates. So opiates are going to slow the mo, right? They're going to maybe constipate the patient, but they'll definitely also help them from having diarrhea. Decreases intestinal motility. I say slow the mo. Probiotics help maintain the microbiomes in the intestine. So if you turn the page to page 714, we've got some antiemetics, antihistamines. I want to call your attention there to the antihistamines. Why? Well, because the elderly are very sensitive to these, and it can make them drowsy. And what happens when a patient gets drowsy? They fall. So we really want to be careful when we give Phenergan or any kind of anti-nausea medications, because it is used to treat nausea, and a patient might have nausea, and that's fine that you give it, but be careful they don't fall because they're going to get drowsy from that medication. So that's really important to remember there. I'll kind of let you read through some of these other lower digestive drug medications. We'll talk about them again when we do our lower GI. But I do, on page 715, I want you to go down to the anti-inflammatory drugs. The 5-amino acylates, cefalazine, azolvidine. These again are GI drugs, lower GI drugs. I'll talk about them later. So just hold on to that thought. We're almost done. If you'll turn the page to page 716, there's some more drugs. These are more colon related. I'll talk about them again later when we get to the lower GI tract. So I'll be pulling you back to these medications. These tables are really important. That's the neat thing about introduction to a system, is because you will be pulled back into those. They're in one place, right? You're not flipping all over the place. All right. So again, on page 717, just to finish up this chapter, it said it's important to monitor GI suction to be sure it's functioning, inspect, describe, and measure the drainage, auscultate the abdomen for distension and bowel sounds. And then after GI surgery, do not irrigate or reposition the tube because it's there for a reason why the doctor wants it there. Notify the RN or healthcare provider if the tube is not draining properly or if the abdomen becomes distended. And remember, if they're getting GI suction, they're probably getting IV fluids to replace what they're losing. We will always want to maintain an I and O, intake and output equal. The patient is at risk for fluid and electrolyte imbalances, so we're always going to be on the alert for low potassium, which would point toward muscular issues, heart tachycardias or muscle aches or twitches. So always be on the alert for that. All right, let's go to the next. I think we got a question coming up. Yep. So question number 1, which of the following is not considered a main part of the digestive tract? I'll give you a second. You're right, it's C, liver, because liver is an accessory organ. Let's go to question number 2. Which is an age-related change in the lower digestive tract? It's B, muscle layer atrophy, which leads to constipation, which is a common problem with the elderly, huh? The muscles just don't, that peristalsis just doesn't move like it should. All the others are wrong. They don't have increased anything, really. Right? All right, thank you. I'll be back to talk about the next chapter.